Hi, everybody, and welcome to the Family Medicine Top Tips and Tutorials. I'm Dr. Madeleine Muller here from CMH in Mtansane. And in this short tutorial, we're going to focus on how we introduce and adjust insulin in a type 2 diabetic patient, and particularly, again, working towards targets. So in a previous tutorial, we looked at introducing our metformin and our glimepiride. We now find that our morning sugar is still over 7, and we want to start looking at giving insulin. So just to remind us a little bit on what insulin preparations we have available and how to think about insulin, when you're trying to give somebody insulin, there are two ways in which you give insulin cover. So the one is what we call our basal insulin. So that's the amount of insulin we need over a 24-hour period to cover our growth, our healing of wounds, our running of our metabolic organs and our autonomic functions. And for that, we need a long-acting insulin. You can see it's that blue line over there that's supposed to cover the whole day. In private practice, we have some lovely preparations that you can do once a day, and it will cover the whole 24 hours. But in the public sector, we have protophane, lasts about 12 to 16 hours, and basically you have to give it twice a day if you wanted to give 24-hour cover of your basal insulin needs. The other insulin that we use is the insulin that you need for food and activities, so things that you do during the day that requires those keys to unlock your cells to get the insulin into your cells. So again, if you are to be completely exact, you would actually want to give an insulin bolus dose before each meal, which would be 3 times a day to cover that meal. In our public sector, we have actrapane available as a short acting. The challenge with actrapane is it takes about 30 to 45 minutes before it really kicks in. So you actually have to take it about 30 to 45 minutes before you have your meal. Otherwise, the actrapane won't cover the peak of the absorption of your sugar in your meal. And the other challenge is that the actrapane stays in the system for a good 4 to 6 hours. So it gets quite tricky. If you wanted to give it 3 times a day, you'd have to make sure your meals are about 5 to 6 hours apart. And this is not always very practical. So what we have in our setting, what we quite often like to use is actraphane. So actraphane combines a basal insulin together with a short-acting insulin. And therefore, the actraphane gets given twice a day. And by giving it twice a day, we're actually only covering our breakfast meal, our meal at breakfast, and our meal at dinner, as well as providing 24-hour of basal. So great. So how do we use this in the type 2 diabetic? So after we've introduced our glimepiride, the next step, if the sugar is still over 7 in the mornings, is to add protophane. So remember I said protophane only covers 12 hours. And so when we're giving it at the beginning, we're only giving it at night. And all you're actually doing is you're just covering the evening basal insulin need. So you're not actually covering the daytime. There's a basic unit that you can start, about 0.3 units per kilogram. That works out to about 10 or 20 units that you will start. They always take it at night. And ideally, if your patient was to come back quite often, or if they were quite able to take it on themselves, you can, every 2 to 4 days, you can titrate it up. And I'll show you the titration in a minute to get that up to target. And the way you know you're at target is by looking at what your morning sugar is doing. So once your morning sugar is under 7, you know that you're having enough protophane on board. So there's a maximum amount, which is 0.5 units per kilogram, which works out to about 30 to 40 units. But the reality is you might sometimes get to a point where in the morning, the sugars are very nicely controlled. You're a bit nervous going up with the protophane because they're going to get hypoglycemic, but your evening your HbA1c is still high. And that normally means, no, actually, we're going to need 24-hour cover, and it's time to introduce your actraphane. So to monitor this, as I've said, you want to do your morning blood glucose before they eat anything to be able to monitor. We generally say take it before you go to bed, 10 o'clock at night. It doesn't actually make any difference on when exactly you give it, and it's not related to food. If you now get to the point where your HbA1c is not under control or they're on the maximum dosages of protophane or the morning sugars are still over 7, then you might want to go on to your next step, which is your actraphane. So remember, I said this is twice a day. And there are some recommendations on what dosing you start. But quite often, if you've already got the patient on protophane, you can use that as an indication of how much you want to start, or you want to look at the 0.3 units again per kilogram per day and divide that up over the day. And there's this rule of you split it into 2/3 in the morning and 1/3 at night. And the idea is that people eat bigger in the morning or more carbs in the morning and night. And there's also something called the dawn phenomenon, where people need a bit more insulin in the morning than they do in the evenings, but it's a very thumbsuck number. In the end, the amount of insulin that your patient's going to be needing is going to be depending on what his sugars are doing. So it doesn't really matter where exactly you start. Very important, when you tell your patient about the actraphane, they need to take it 30 minutes before they eat, and that is both in the mornings and in the evenings. And you want to set morning and evening preprandial targets, which I will show you in a moment. And we want to titrate the patient's insulin up until you reach the targets. And that's what's going to tell you how much they need in the morning and the evening, and forget about the 2/3 and the 1/3. Just important, while you're on the protophane, you can still continue your sulfonylurea, but if you introduce actraphane, you have to stop your glimepiride, and so the patient will still be on metformin. That'll be quite useful for managing their insulin resistance, and the actraphane then is in addition to help bring their sugars under control. So when we want to titrate the insulin, first thing we need to train our patients who are on our actraphane is that they get very good at actually doing their sugars. Ideally, they should be doing their sugars in the morning before they inject and in the evening before they inject. And remember, we talked about those targets that we set in one of our previous tuts. So if you've got a HbA1c target of 7%, then you want your morning to be between 4 and 7, and you want your evening between 10. Now just watch out, because that evening sugar is actually a random postprandial sugar. So sometimes you might see patients where their evening sugars are great, under 10 always. The morning one is always under 7, but their HbA1cs is still high. That usually means that actually it might be that the amount of actraphane they're having in the day is not covering those peaks of the sugars every time they've eaten. And you might have to ask your patient to take some postprandial values, so 2 hours after breakfast, and then another day take their sugars 2 hours after lunch, and then another day take it 2 hours after supper, and that will give you a trend of where your problem is. So to adjust your patient, you're going to then look at that blood glucose diary. We need to train our patients to bring in those values, and you're going to look at your morning blood sugar to adjust your evening actraphane. This little table here is from the GEMSDA guidelines, and it's specifically designed for protophane, but it's got a similar principle. And basically the idea is the more readings you have, the more aggressive you can be in terms of how much you increase that insulin by. So in the morning, if you only have 1 or 2 readings, or if you only have that morning's reading, you're not going to be that aggressive. You might only go up by 1 unit if the sugars are not on control. But if you've got 3, 4, 5 days or a whole week's of readings, and it's consistently, for example, between 7 and 8, you might decide to actually put that dose up by 4 units. So remember, your morning sugar is going to determine what you're going to do with your evening actraphane, and your evening sugar is going to determine what you're going to do with a dose of your morning actraphane. If you're quite specific every time you adjust on how you get to your adjustment levels, you'll soon get your patient onto target.